So now in this video, we are going to discuss about the absorption. So what is absorption? Absorption is defined as movement of drug from the site of administration into the circulation, right? So if you are taking a drug orally, then orally it reaches the stomach, and from the stomach, then it has to reach the blood. So absorption is basically the movement of drug from the stomach into the blood. That is absorption. Now, only when the drug is given intravenously, the absorption is found to be 100%. But if it is given by other routes like oral or like intramuscular or subcutaneous or topical, then the absorption is less than 100%. So let us see what are the factors which affect the absorption. Now the factors, the first factor, the very important factor is aqueous solubility. Anything which is a watery solution is absorbed faster than a solid or an oily solution. So remember this, an aqueous soluble thing is always absorbed faster. Concentration gradient. Now whenever there is a concentration gradient, the absorption will be more from higher to lower side. So passive diffusion will be more from higher to lower concentration gradient. Area of the absorbing surface. If the area is big, then the absorption is more. So larger is the surface area, faster is the absorption, and that is why the absorption is faster in the intestines, because in the intestines there are a lot of villi, and so if you spread that villi, it becomes a very big surface area. Next is time. Now time, more the thing is, more the drug is in contact with the absorbing surface, more is the absorption. So more is the duration that the drug is there in contact, the absorption is faster and more. Thickness of the surface. It is seen that thinner the surface area, faster is the absorption, and that is why mucous membranes are more faster absorption than compared to the skin, because skin is thicker, mucous membrane is thinner. Vascularity of the surface. So whenever there's an increased blood flow, the absorption will be more. And then the last factor is the route of administration. So whichever route you use, it will have its own characteristics and it will affect the absorption. So let us see the route wise. Now the first route that we have to see is the oral route. Now in oral route, understand the first factor is a lipoidal membrane. When you take anything orally, then inside we have mucous membrane, and all the mucous membrane, as we discussed, are biological membranes having hydrophobic ends inside, hydrophilic ends outside. So only lipid soluble. If a drug is lipid soluble, it will travel faster. If it's water soluble, thoda slow hoga. The second factor, as we discussed in the earlier video, is ionization. So acidic drugs, they are unionized in the stomach, and so they are absorbed from the stomach. While basic drugs, they are unionized in intestine and they are absorbed from the intestine. This we have seen in the earlier video also. The next factor is dissolution. That is, every drug is made up of particles. Particles are there. So particle size governs the rate of dissolution. If the particle size is small, the rate of dissolution is going to be faster. Another type of tablets that we have are mouth dissolving tablets or effervescent tablets. They dissolve faster. So that is why some tablets, they are given, and then you must have seen that you put them in water, and then some bubbles come up, and that you just have to drink it. So that is an effervescent tablet. And when you make an aqueous solution, then the absorption becomes faster. Now when you are eating something, so presence of food will dilute the drug and retard the absorption. So the absorption is going to be affected by the presence of food, presence of drugs, presence of other content in the stomach. What happens is that when you take a drug with a food, for example tetracyclines, they chelate with the calcium in the milk. So if you take tetracyclines and then you take milk, then this tetracycline will chelate with the milk and the absorption will reduce. So that is the fundamental why drugs are given empty stomach, because they get absorbed better. There is no other entity to interfere with the absorption. Now another exception in this is that there is a drug called as lumefantrine, and it is seen that fatty food increase the absorption of this drug, right? Next is area. So faster absorption is seen from the intestines than the stomach, because intestine has got a bigger surface area. Susceptible to gastric acid and digestive enzymes. Yes. Now again, when you're taking a drug by oral route, then drugs can be degraded by enzymes, like penicillin G is destroyed by the gastric acid. Then drug-drug interaction, and that is called as a luminal effect. What happens is, when you take a drug, when you take multiple drugs together, then one drug can alter the absorption of another drug. They can form insoluble complexes, like tetracycline forms a complex with calcium, iron forms a complex with antacids. They can also affect the motility. So some drugs can increase the motility, hasten the movement of the drug in the intestine, and thus reduce the absorption. The next point is alteration of gut flora by antibiotics. So some antibiotics, they disrupt the enterohepatic cycling. By altering the gut flora, we actually interrupt the enterohepatic cycling. Like OCPs, digoxin, these drugs, they metabolize by enterohepatic cycling, and this can be disrupted. Then other effects are gut wall effect or mucosal damage, which can be caused by drugs, and thus they interfere in the absorption of other drugs. Coming to the next route, that is subcutaneous and intramuscular. Now in subcutaneous route, again lipid solubility is very important. Lipid soluble drugs are seen to pass easily. Second, absorption from subcutaneous site. This is very important. Absorption from subcutaneous site is slower than the intramuscular site because the intramuscular site is more richly vascular. We all know that intramuscular area is supplied more richly by the muscle, by the vessels, blood vessels. But anyways, both are faster and more predictable than the oral absorption. Oral se to subcutaneous and intramuscular fast hote hain. Then heat and exercise. You must have seen that if you rub the lotion on the skin, then it increases absorption. So it accelerates by increasing the blood flow. Actually, when you are rubbing on the surface or when you are applying heat, you're causing vasodilatation and increasing the blood flow. Then vasoconstrictors. So there are some drugs when they are given, say adrenaline, which is a vasoconstrictor. When it is injected with local anesthetics, it will reduce the, the movement of the drug away from that site, and it will increase the duration of action of local anesthetic. So when suppose there's a cut on the skin and you have injected a local anesthetic and you want the local anesthetic to remain there for some time, in the meanwhile you can do the procedure. So there adrenaline is given with this. So adrenaline will cause vasoconstriction and will limit the local anesthetic in that area. Similarly, ice application, it causes vasoconstriction and lets the drug remain in that area for a longer time. The next area that we discuss is topical sites like skin, cornea, mucous membranes. Now here again the important pointers are lipid solubility. So more lipid soluble drugs absorb better from the topical sites. When you rub the skin, then you get a faster absorption. If you use an occlusive dressing, then it will keep the hydration intact in that area and will increase the absorption. Cornea is seen to be permeable to lipid soluble unionized drugs and not to highly ionized drugs. So those drugs which are like neostigmine is ionized, it is not effective in cornea, while physostigmine is found to be effective. And mucous membranes, they absorb lipid soluble drugs faster than skin. So that is why, oral, the route that we have is buccal or rectal or vaginal routes. These are faster acting as compared to the normal skin, and they are found to have much faster action, right? The next fundamental that we have to discuss after absorption is bioavailability. Now, what is the meaning of bioavailability? Bioavailability is basically a measure of fraction of administered dose of a drug that reaches the systemic circulation in unchanged form. Okay, so here the word that is important is unchanged form. So bioavailability, or F, is basically the drug that reaches the blood in unchanged form. That is the most important. A drug will reach the system after metabolism in changed form. That is not the bioavailability. For example, I'll give you an example. That suppose you ordered 10 packets of milk from the dairy, right? Now out of that 10 packets, when the person was bringing it, 2 packets got torn. So now you get 8 packets only, right? So here the bioavailability is 8 packets. He might bring the 2 torn packets also, but they are changed form, so you cannot accept them. So the drug that reaches the systemic circulation in unchanged form is the bioavailability. Now understand that when a drug is given by IV route, the bioavailability becomes 100% because here it is, you're actually putting the drug into the blood circulation. While orally or by any other route, the bioavailability is always less than 100%. Now oral drug, why it happens? Because oral drug is always incompletely absorbed. And secondly, the absorbed drug undergoes first pass metabolism in the liver. So we will understand what is first pass metabolism when we study about metabolism, right? Now here I have drawn a plasma concentration curve. On the x-axis we have time, on the y-axis we have the concentration, and here I have drawn 3 graphs, A, B and C. These are basically graphs showing 3 drugs, okay? That with the passage of time, what was the concentration of that particular drug? And here the line indicates therapeutic concentration. So that means a drug will have therapeutic effect only when the concentration reaches above the therapeutic concentration margin. Okay, अगर उस तक नहीं पहुंच रहा है ड्रग का concentration, तो फिर वो इफेक्ट नहीं लाएगी हमारी बॉडी में. So now here you can see that area under the curve for A and B is same, but B does not achieve the therapeutic concentration, so it will not have a therapeutic effect. While A is reaching the therapeutic concentration and going above it, so it will bring a therapeutic effect. And C in the meanwhile is not not achieving, so less absorbed, so it does not have any effect. Now with the bioavailability, we also have another concept that is called as bioequivalence. What is bioequivalence? Basically, bioequivalence means that oral formulations of the same drug from different manufacturers may have same amount of drug, but they will not yield the same results. So that means they are chemically equivalent, they have the same. Suppose we are testing 2 drugs of paracetamol 500 milligram. One is called as crocin, one is called as Calpol. So now both are chemically equivalent because both have got 500 milligram of paracetamol, right? But when you see the effect, So it is seen that crocin 500 milligram brings better effect, brings more faster temperature control of fever. So it is seen that biologically they are not equivalent, biologically inequivalent ho rahe hain. So two preparations are called as bioequivalent only when the rate and extent of absorption from the drug or bioavailability of the drug is same under suitable test conditions. Okay, so this is bioequivalence. So what is the difference here? See, that what happens is that when a drug is orally administered, now what are the factors which make drugs bio-inequivalent? When you orally administer a drug, then it breaks down. That is called as disintegration. Now, once the drug breaks down, now disintegration is governed by the excipients which are added in the drug. There are some coloring elements, some stabilizing agents, some emulsifying agents will be there. So excipients, they matter. And then the force which was used to compress the medicine in the manufacturing lab, because medicines are manufactured in factories. So the force which was used to compress the medicine, that will decide the disintegration of the medicine. And after that, the next is dissolve in the aqueous GIT fluids. Once it disintegrates, it has to dissolve in the GI fluids. So this dissolving in the GI fluids is called as dissolution. And what are the factors which determine that? The aqueous solubility of the drug, particle size, and crystal form, etc. So now the disintegration and dissolution rates, they determine the bioequivalence. Poorly soluble drugs, slowly absorbed drugs usually are not bioequivalent. Also, particle size is very important, and so nowadays you will see that the drugs are really microfined. Microfining will increase the absorption. Now, why do we study this? Why हमें क्यों पढ़ना है ये? Significance क्या है? It is significant because drugs who are having low safety margins, they are important, like digoxin. This is a heart-saving drug. Now, suppose what happens that bioequivalence. Suppose in a home, a patient is taking, say, drug A, say drug A of digoxin he is taking, and or any other antihypertensive drug, and this drug gets over or finished, and they don't have the this drug, मतलब इनकी दवाई खत्म हो गई. So what the son does, he goes to the pharmacy, and in the pharmacy he goes and purchases drug B of digoxin. Same, everything same, 500 milligram, 200 milligram digoxin उसने खरीद लिया drug A की जगह drug B, किसी और कंपनी का, some other company drug B. Now he brings it home and he gives it to his father. But after some days, his father feels dyspneic. His father starts feeling dyspneic, as in his father has difficulty in breathing. So he goes to the doctor. Now he goes to the doctor. Doctor को बोलते हैं, we are taking the same medicine, we have not changed the medicine, then why it is happening? Doctor says, कौन सा दवाई खा रहे हैं? He will take out the tablet, he'll show, and then you will find that the drug A and drug B are from different companies. Now the effect of drug B is not able to simulate that effect, and that is where this is happening. Why? Because they are biologically inequivalent. Bioequivalence is not there. And this is the significance of bioequivalence, that when you change the drug, when you change the brand drug, the main generic drug will remain the same, but when you change the brand name, किसी और कंपनी का लेते हैं, तो फिर then the effect differs. And that is why bioequivalence is important in drugs which have a low safety margin, drugs which need a precise control, for example, oral hypoglycemics or oral anticoagulant drugs. These are life-saving drugs. You cannot, उनके साथ आप छेड़छाड़ नहीं कर सकते हो. Then infection control, antibiotics. You take an antibiotic of some company and then वो खत्म हो गई, you take antibiotic of another company. The pharmacist will say, same दवाई है, आप ले लो. And you take it and then the effect doesn't come. The infection continues. This is because both the drugs were biologically inequivalent. So this is the importance of biological equivalence or bioavailability. Now the next topic that we have to discuss in pharmacokinetics is called as distribution. What is distribution? Distribution, after absorption, the drug is distributed to the organs of the body through blood. So once the drug has been absorbed from the stomach or any other site, say intramuscular, subcutaneous injection, then the drug has to reach the target organ by the bloodstream. That is distribution. Okay. So definition, if we talk about the definition, see, now please understand this very properly. Presuming that the body is a homogeneous compartment with a volume V, into which the drug gets uniformly distributed. Now see here, what the problem is that our body is actually a multi-compartment model, है ना? Multi-compartment है हमारी body, भाई उसमें different organs है, उसमें muscle है, fat है, kidney, heart, liver, brain, lungs, ये सब organs हैं, fibrous tissue है, so a lot of compartments are there. And the drug actually gets distributed in all these multiple compartments. But to make it simplified or to understand it in a simplified manner, we take the body as a homogeneous compartment having particular volume V. Okay. Now, we understand that the drug is getting uniformly distributed in this compartment. So then the formula for volume of distribution. Now what does this A stand here for? This A is actually apparent. Apparent मतलब आभासी, दिख रही है पर है नहीं. So VD or volume of distribution is equal to dose administered intravenously upon plasma concentration. Okay, this is the formula for volume of distribution. So it is basically an apparent volume of distribution. This is the volume in which the drug will accommodate if the concentration throughout is same as in plasma. Okay, now see why we are using apparent. I'll give you an example. The drug is injected into the blood and the dose of the drug injected is 1000 milligram, right? The plasma concentration when it was seen is 50 milligram per liter. Okay, मतलब 1 लीटर में 50 मिलीग्राम है. तो उस हिसाब से वॉल्यूम ऑफ डिस्ट्रीब्यूशन कितना हुआ? 1000 milligram upon 50 milligram per liter. That means volume of distribution क्या हुआ? 20 liters. That means आपने 1000 milligram जो डाली तो 50 milligram हर लीटर में थी, तो उस हिसाब से बॉडी की वॉल्यूम ऑफ डिस्ट्रीब्यूशन उस ड्रग की 20 लीटर है. बट हमारा जो पूरी बॉडी में वाटर कंपोनेंट जो है वो अराउंड 5 लीटर है. प्लाज्मा हमारा 5 लीटर है, राइट? प्लाज्मा 5 लीटर है, तो दैट मीन्स कि 20 लीटर में ये ड्रग डिस्ट्रीब्यूटेड है. तो ये कहाँ गया फिर? बाकी का 15 लीटर कहाँ से आया? तो 15 लीटर बेसिकली बॉडी के ऑर्गन्स में गया, ECF में गया, ICF में गया, अलग अलग जगहों पे गया. तो इसीलिए ये आभासी वॉल्यूम हम कहते हैं, इसीलिए इसको हम बोलते हैं अपरेंट वॉल्यूम. मतलब ये एक अपरेंट वॉल्यूम है, ये एक्चुअल वॉल्यूम नहीं है. दिस इज एन अपरेंट वॉल्यूम इन विच द drug is distributed if the concentration throughout is same as in plasma. Okay, and this is the formula, this is the definition which you are supposed to write in the exam if it comes. So let's see now what are the factors which affect the distribution. So as usual, the first factor is lipid solubility. More is the lipid solubility, more is the volume of distribution, because the drug is going to go into many tissues by passive diffusion. It will cross the membranes. If there is a less lipid solubility, then the drug will be restricted to the ECF compartment only, and VD will be almost the same as ECF. Then if a drug is having a large molecular weight, then also it is going to have a less volume of distribution because it will remain restricted to the plasma or the ECF only. If the drug is having high plasma protein binding, then also the drug has a less volume of distribution and is restricted to the plasma only. So a drug, this is a very simple concept to understand, that if a drug is small in size, if the drug is lipid soluble, if the drug is not bound to the big plasma proteins, then it is going to be distributed far and wide in the body. But if the drug is not lipid soluble, it is attached to the big plasma proteins, it is having a large size molecular weight, then it will not go to far off places in the body and it will remain restricted to the plasma. Then we have ionization. So a drug, this ionization, we know the concept that unionized drug will get absorbed, will pass through the membranes, so it will have a more volume of distribution. Then if a drug has a tendency to get stored in a tissue or sequestrated in a tissue, then it will also have a high volume of distribution. Then if the regional area blood flow is good, then again the volume of distribution is going to be high, because that blood flow will take the drug to other places. Fat lean body mass is also important. So in females have got a higher fat, है ना? Females का fat lean body mass ज़्यादा होता है. So then lipid soluble drugs have a higher volume of distribution in fatty people. Then in disease conditions like CHF, uremia, cirrhosis, where the proteins, the plasma protein concentration can change, the body water changes, the binding proteins change, then in that case volume of distribution also gets altered. Then what is the clinical significance of this? Why we are studying this? We are studying because in poisonings, पॉइजन होता है, एंड अगर उस ड्रग का, सपोज किसी ने सुसाइडल के कारण कोई ड्रग ज्यादा क्वांटिटी में इंजेस्ट कर ली. नाउ इफ द ड्रग हैज गॉट अ वेरी हाई वॉल्यूम ऑफ डिस्ट्रीब्यूशन, देन इट विल बी डिफिकल्ट टू रिमूव इट बाय हेमोडायलिसिस. ओके, सो दिस इज द क्लिनिकल सिग्निफिकेंस ऑफ नोइंग द वॉल्यूम ऑफ डिस्ट्रीब्यूशन ऑफ अ ड्रग. देन इन डिसीजेस वॉल्यूम ऑफ डिस्ट्रीब्यूशन गेट्स ऑल्टर्ड, सो दिस इज ऑल्सो वेरी इंपॉर्टेंट. Now in the distribution we have a new concept which is called as distribution. What is redistribution? Redistribution क्या होता है? That when the drug is very highly lipid soluble, then initially it will get distributed to the organs which are having a high blood flow, like brain, heart or kidney. But after some time, the drug has a natural affinity to move towards bulky areas, fatty areas like muscle and fat. So the drug slowly and slowly, then if it is a highly lipid soluble drug, it will have an affinity towards fat. So it will move towards fat. So that is redistribution. It will get redistributed towards fat, and as a result, the plasma concentration will fall, and then as the drug is drawn from highly perfused sites, so there will be termination of action in the area where it was supposed to work. So here we have an example. Thiopentone is a general anesthetic, and this thiopentone is used in surgeries, okay, to produce anesthesia. Now this thiopentone, if you give a single dose, if it is given in a single dose, then what happens after some time? the drug goes to the fat and the patient wakes up. Now you can't afford waking up a patient in surgery. So then what do? We give an infusion of thiopentone. Continuous infusion goes on, and this infusion will do what? It will saturate the fat tissues. The drug will remain in the brain for a longer time and the surgery can go on uninterrupted, right? So this is the redistribution phenomena. It is seen with thiopentone, and redistribution means the drug first reaches the highly perfused organs, but then because it is highly lipid soluble, it gets redistributed to fatty tissues. The next thing that we have to study is now the brain and CSF. Now we are talking about redistribution, so let's understand the various organs also. So brain has got a blood-brain barrier and it also has a blood-CSF barrier in the choroid plexus. So now both the barriers are lipoidal. So lipid-soluble drugs will cross, but non-lipid soluble drugs will not cross. Okay, so you know that blood-brain barrier is very tight at all the places except deficient in one or two places. So lipid soluble drugs can cross, and it is another mechanism is that there is P-glycoprotein and organic anion transporter which extrude the drugs out. Even if some drug reaches and it is toxic, then it extrudes, it removes the drug. So we all have heard about levodopa, which is basically used in Parkinsonism. Now Parkinsonism is a disease which occurs because of deficiency of dopamine. Now if we give dopamine like that, it will not go into the blood-brain barrier, it will not go in the brain, and we want dopamine in the brain. So because dopamine cannot go, we give levodopa because it crosses the blood-brain barrier. Then inflammation of meninges. Whenever there is an infection of the meninges, there is an increased permeability and drugs can traverse through the membranes. Now this is important. The blood-brain barrier is deficient at CTZ, that is a chemoreceptor trigger zone. So suppose you take some emetic drugs or emetic substance, then it reaches this area and can directly trigger the vomiting. Then anterior hypothalamus, pineal gland, subfonical or subcommissural areas are also deficient in blood-brain barrier. Then next, exit of drugs from the CSF and brain is free. The drugs can freely exit. The next area is important, placenta. Now placenta, why it is important? Because there's a fetus inside that womb and any drug taken by the mother can affect the child also. Now the membrane of placenta is lipoidal, so it allows lipid soluble drugs freely. And there is an efflux transporter, that is P-glycoprotein, to extrude the extra or excess drugs also. But it is seen that if you give lipid insoluble drugs in high concentrations, then in high concentrations they may enter and can affect the fetus. Placenta is an incomplete barrier and drugs can affect the fetus. Like morphine, when it is given to the mother, then it can result in respiratory depression in the fetus. So placenta is a very incomplete barrier, and that is why a lot of drugs, we have a separate section, drugs which can be used in pregnancy. A lot of drugs are not used in pregnancy because they have adverse effect on the child, or what is called as teratogenicity. Now the next fundamental that we have to discuss is called as plasma protein binding. Coming to the next topic, that is called as plasma protein binding. Now plasma protein binding क्या होती है? The drugs, when they travel in the plasma, in the blood, they bind to proteins. अकेले नहीं जाते हैं, right? अकेले, they don't want to go alone. So the drug, it binds with proteins when it is traveling in the plasma. Okay. Now acidic drugs, they bind to plasma albumin, and basic drugs are found to bind to alpha-1 acid glycoproteins. These are plasma proteins, right? So what is the clinical significance? Now let us understand what all things can happen because of this plasma protein binding. The first thing is that the drugs which are highly plasma protein bound, they remain restricted to the vascular compartment because the plasma protein is of big size and a big molecular weight. So it keeps the drug in the vascular compartment. It does not cross the membranes and it does not go to the tissues. So because plasma protein bound drugs are big in size, so they do not cross the blood-brain barrier and the membranes, and hence they have a very small volume of distribution. Okay, so remember that drugs which are highly plasma protein bound have a low volume of distribution. Then the bound fraction is not available for action. What happens is the free component and the bound component, they remain in an equilibrium. जैसे ही free component खत्म होने लगेगा, the bound component will release some drug into the free part. So this bound drug, it acts as a temporary storage, and as a result, because slowly and slowly the bound component is released, the drug becomes longer acting. All the drug is not available as the free component. So free कम है, and जब ये खत्म होता है तो bound drug अपना release करती है थोड़ा सा, and as a result the drug becomes longer acting, right? Then the next thing is that a highly plasma protein bound drug cannot be removed by hemodialysis. So earlier we had studied that a high volume of distribution drugs cannot be removed by hemodialysis, but also if a drug is highly plasma protein bound, it also cannot be removed by hemodialysis. Then when there is a plasma protein binding, then there are going to be displacement interactions because the same drug can bind to the, same protein can bind to many drugs. So many drugs will compete to binding to the same protein. उसमें क्या होगा? The higher affinity drugs will displace the drugs having lower affinity. So these displacement interactions also play a very important role in the action of the drug. Whenever there are any disease states, like hypoalbuminemia is there, then in hypoalbuminemia, due to decreased albumin, there will be decreased plasma protein binding and there will be more free drug in the circulation. In that case, we will have to reduce the dose. We'll have to reduce the dose because the free drug component is more in the circulation, so the action is going to increase. Similarly, like propranolol binding is found to increase in pregnancy and inflammatory diseases. Why? Because in inflammatory diseases, there is found to be increased alpha-1 acid glycoprotein. So you have to increase the dose when there is more plasma protein binding, right? Then in that same thing, we also study about the tissue storage. Now it is seen that drugs having a large volume of distribution and the drugs which usually get sequestrated in the tissues have a large VT, they have a longer duration of action, and they also have local toxicity because they are getting attached to the tissue, and that attachment to the tissue will result in toxicity. So what are those drugs? Like tetracyclines have a attachment or a tendency to or an affinity with bone and teeth, and they can result in damage to the dentition, damage to the bones, right? Heavy metals, they have got an affinity with bone and teeth and they cause the damage there. Digoxin, emetin, they go and sequester in the skeletal muscles. Chloroquine gets deposited in retina and can cause retinopathy. It also gets deposited in liver. Streptomycin has got an affinity with the ear, basically with the vestibular apparatus, and there it causes deafness due to attachment with the vestibular apparatus. Then atropine or ephedrine has an attachment or an affinity with iris. Iodine is attached to thyroid. Chlorpromazine or isoniazid is attached to brain. Chloroquine, emetin, they are attached to kidney. So these are the drugs and they get sequestrated in the tissue and cause long-term toxicities. Now after this, we will be studying about the metabolism or the biotransformation of the drugs.